Good morning, everyone, and welcome to today's webinar, Obstetric Outcomes in IVF Pregnancies. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contract hour credit. The certificate will be emailed to you to the email you RSVP'd by Harvard going around July or August. Additionally, we encourage you to submit questions to Dr. Rossi using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speaker. Dr. Brooke Rossi is a board-certified reproductive endocrinologist at Ohio Reproductive Medicine. Dr. Rossi is a graduate of the University of Pittsburgh School of Medicine and completed her residency in obstetrics and gynecology at the University of Rochester. Her subspecialty fellowship in REI was completed at Brigham and Women's Hospital and Harvard Medical School. Her clinical interests include recurrent pregnancy loss, polycystic ovarian syndrome, and minimally invasive surgery. She also has a special interest in life factors, fertility, and in vitro fertilization. She has been published in Obstetrics and Gynecology, Fertility and Sterility, and the Journal of Clinical Endocrinology and Metabolism. Dr. Rossi is an adjunct assistant professor in the Department of Obstetrics and Gynecology at the Ohio State University. She is a member of the American Society of Reproductive Medicine and American College of Obstetrics and Gynecologists. All right, we're going to get started. I'm going to pass it over to Dr. Rossi.
Hi, everyone. Thanks so much for joining us today. When I was asked to give this talk, I was thinking about different things that I would like to talk to healthcare providers, OBGYNs, primary care doctors about. And I thought to myself, well, you know, there are some differences that we know about with IVF pregnancies, but I'm going to just review the literature and let people know about all the things they don't need to worry about. These women are just like everybody else, and I'm just going to make people understand they don't need to take things so, you know, be so concerned about their IVF pregnancies. But as it turns out, this gave me a good opportunity to review all the recent literature. And what I learned from preparing this talk is that there are differences, pretty significant differences, a lot of differences with IVF pregnancies compared to spontaneously conceived pregnancies. So that's what we wanted to talk about today. Before we start the heart of the talk, I just want to go through a couple terms so we're on the same page about different things that we're discussing. So this talk is really focused on in vitro fertilization or assisted reproductive technologies, and that really does include in vitro fertilization and ICSI. This is actually a picture of ICSI. That is what we use when we put the sperm directly into the egg to fertilize the egg. There are other infertility treatments, oral medications like clomiphene citrate or letrozole. Sometimes we use trigger shots for these patients. There's also gonadotropin therapy, in which patients use hormone injections of follicle stimulating hormone to help them try to conceive. And then, of course, there's intrauterine insemination, which can be either partner sperm used or donor insemination. So although we'll kind of mention these treatments, really what we're focused on are these treatments related to ART. So who are your patients that might be undergoing ART or IVF? Probably some of the more common reasons would be tubal factor infertility. So these are patients maybe who have had a tubal ligation or have abnormal tubal function. One of the other main reasons that patients do IVF, and possibly with intracytoplasmic sperm injection, would be for severe male factor infertility. But we have a lot of other patients who will do IVF for other reasons, including unexplained infertility, meaning all of their testing is normal, but they're not able to achieve a pregnancy either on their own or with intrauterine insemination, endometriosis, decreased ovarian reserve, and sometimes patients with recurrent pregnancy loss who choose to do additional testing of their embryos. They may also proceed with IVF. We can do genetic testing of embryos, and that may be used for patients who have genetic mutations. They may be carriers of they and their partners may be carriers of recessive diseases that they don't want to pass on. So they'll do IVF to then do genetic testing of the embryos. And then we have a great increase in patients proceeding with fertility preservation. And the most recent numbers that came out from a national organization said that there's been about a 30 to 40% increase and women choosing to freeze their eggs. So when people freeze their eggs, they need to freeze their eggs, they need to proceed with ovarian stimulation, much like we do with IVF. And then when they go to use their eggs in the future, that basically they have to do the second half of the IVF process to fertilize the eggs in the laboratory and create embryos. It's very important that we're going to be talking a lot about different types of IVF. And so we're going to be talking about two different types of embryo transfers. A fresh embryo transfer is when a patient undergoes ovarian stimulation, and then about 5 days after she has her eggs retrieved, an embryo is put into her body. So the whole IVF cycle takes part in about 1 month. A frozen embryo transfer means that the woman undergoes ovarian stimulation, then that embryo is created and usually frozen at the blastocyst stage for future use. It might be 1 to 2 months later, it might be 1 to 2 years later. The other technology that we'll be discussing is called preimplantation genetic testing, or embryo testing. And we do embryo testing for a couple different conditions, or for a couple different reasons. So I would say the most common is to do something called PGT-A, and that's testing the embryo to see if it is euploid or has the right number of chromosomes. So we're looking for aneuploidy. So an example of this would be testing an embryo and finding out that it has an extra 21st chromosome or has a condition that's associated with Down syndrome. For our patients for which they and their partner carry a recessive disease, we can create a probe which then looks for that specific disease in an embryo. So if we had a patient who had, she and her partner had sickle cell, we would do PGT-M looking for this to see if the embryo carried the sickle cell genes. And then for our patients who have balanced translocation, they may undergo IVF and then do PGT-SR, which helps to see if their embryos are unbalanced or may result in a loss. So I think this is a good just pictorial representation of all the things we're talking about. So a fresh transfer means that we do IVF and immediately in the same month have the embryo go into the patient. Frozen transfer means the embryo is created, frozen, thawed, and then there's an embryo transfer done at a later date. Currently, we are doing most of our embryo transfers on day 5 or at the blastocyst stage, but there are still some reasons why we may consider doing a day 3 embryo transfer. So the embryo is created, 3 days later, it is put into the patient. More commonly, we are doing a day 5 embryo transfer or a blastocyst transfer. So we say day 5, but really that embryo may be frozen a lot of times on either day 5, 6, or 7 at the blastocyst stage. Most of the time we are doing single embryo transfers, and occasionally there are patients, especially those who are maybe over 38 years old, that are having more than 1 embryo transferred at a time. The practice of IVF definitely has changed over time. And so there are differences now compared to, even several years ago. I would say some of the more current trends in IVF right now are doing blastocyst culture and blastocyst transfer, and potentially the increased use of ICSI. Now, ICSI, as we'll talk about later, does have some risks and benefits associated with it. There are some clinics who do ICSI on all patients, regardless of whether there is an issue with the sperm quality, and other clinics will be more selective or only use ICSI for those patients who have an issue with the sperm quality. We have made great strides over the years with reducing patients' risk of ovarian hyperstimulation syndrome. We use specific protocols, we use Lupron-only triggers, we do a lot more freezing of cycles, and it is very unlikely that we have patients now have severe ovarian hyperstimulation or admitted into the hospital with this. So that's been a great change, even in the 15 years that I've been doing this as well. We have more patients who are doing embryo testing, mostly PGT-A. There are some clinics that will recommend that all patients do this, and there are other clinics that use more guidelines or are more selective about the patients who may use this. This can vary from state to state and from clinic to clinic. Single embryo transfers are definitely the standard of care at this point. The most recent, there's a Society for Assisted Reproductive Technologies. They came out with their recent report in the last month saying that at least 85% of embryo transfers that are done now in the US are with 1 single embryo, which is great. We're having more of an increase in freeze-all cycles. This is probably related to possibly an increase in genetic testing of embryos. And as we talked about, there's been a big increase in egg freezing as well. In preparation for this talk, I was fortunate enough to come across this guideline. So last year in the Gray Journal, the SMFM published this guideline, which is exactly what we needed to discuss today, which is how do we manage patients that have pregnancies that have resulted in IVF. So what I will do throughout this talk today is talk about some of the risk factors we see. And when there's a guideline, of which there's probably about, I don't know, 10 or 12 of them, that is related to the topic we're discussing, I will make sure that we draw your attention to it. And then at the end, we're going to go through the guidelines as well. But I do think that this is what we should be following when we're considering how to take care of our patients. Specific outcomes that we're going to be discussing today will be the risk of antenatal hospitalization, maternal morbidity and mortality, the risk of gestational hypertension or gestational hypertensive disease and gestational diabetes, differences we see in birth weights of infants, differences in birth defects, the risk of multiple gestation, and then a little bit more about preimplantation genetic testing. So first, let's start with antenatal hospitalization. So this was a nice study that came out in the Green Journal from a few years ago, looking at a retrospective cohort of patients. And they looked and linked different IVF factors, hospital records to see the risk of having a hospitalization when pregnant for patients who had IVF versus patients who conceived spontaneously. And it was found that ART was a risk factor for having an antenatal admission. And if we looked at the different reasons, for all the patients who didn't do IVF or had multiple gestations, preterm labor was the most common reason they were admitted. And for people who had undergone IVF, vaginal bleeding was the most common. They did also find that the lengths of stay were longer for patients that did IVF, so about 9 days versus about 5 days for patients who had not undergone IVF. Within the group of patients who did IVF, there was no difference in sort of whether it had fresh or frozen and whether it did ICSI or not. And so the ART patients, as we can see here, did have more bleeding, more preterm labor, and more hypertensive disorders. So we can see the rates here. So we have our non-ART or ART. And the authors did speculate that there could have been an issue, in this study, as we'll review later on. This study did not try to figure out people who had infertility versus people who had infertility and got treated with IVF versus people who conceived spontaneously and didn't have infertility. So one of the things that they spoke about with this study was there an impact of subfertility in these patients? Or are IVF patients considered different? Like, do we watch them differently? Do we worry about them more? Are they more likely to be admitted because we think that they're pregnant, because somebody spent 5 years trying to get pregnant? So that may also impact essentially why we're seeing maybe longer admissions for these patients as well. In regards to maternal morbidity and mortality, so this was a very big study that looked at SART data. So I want to talk a little bit about some of the data that we have access to in these studies. So in the United States, the Society for Assisted Reproductive Technologies, most clinics, I think about 80 or 90% of clinics belong to SART, and we have to report our data to them. So what that means is everyone who does IVF, we have to report to them what happened with their cycle, were there any problems with the cycle, birth defects, birth weights, any complications from the cycle. And then all of that data is pooled and can be used for big studies like this. And there are a couple other different organizations throughout the world that do that as well, which we'll show. But the SART data is very useful because it really allows us to look at what's happening nationally and not just at specific clinics. So in particular, this was a SART study of 8 different states where they looked at egg donors and fresh cycles and frozen cycles. And they also were able to look at a subfertile population. So they were able to understand people who maybe had infertility diagnosed, or they could see that that was on their birth certificate. And they used a logistic regression analysis to do these calculations. So what they found was that their risk of severe maternal morbidity was increased in the subfertile patients and those patients who did IVF. And we saw that this was highest in women who used egg donors and people who had fresh cycles. So let's look at some of these. So you can see here, these are the outcomes across the top. And then we have fertile, subfertile. These are fresh cycles using own eggs, frozen cycles using own eggs, and then donor fresh, donor frozen embryo transfers. So like if we look at the risk of having a blood transfusion, even the subfertile patients who conceived on their own had a greater chance of needing a blood transfusion compared to the fertile population. But if we look at women using an egg donor who had a fresh cycle, we can see it's an even greater risk. And we can see the same with, having a 3rd or 4th degree laceration. So the adverse maternal outcomes associated with IVF may also be related to an underlying infertility, but probably IVF kind of compounds the risk as well. One of the themes that we see through caring for patients and through these studies, and what I'll be talking about throughout this talk, is the impact of the placenta on some of these outcomes. So there seems to be differences in the placenta function, shape, and different outcomes with patients who've done IVF versus spontaneously conceived pregnancy. And so if you think about what we've already talked about, vaginal bleeding, maybe a hypertensive disorder, that all can be related to the placenta function. But they also see higher rates of abnormal shapes, marginal placentas, velamentous cords, previas, vasoprevia. We don't know exactly what the cause of this is, but it may be that the trophoblasts are dysregulated and it may affect the endometrial implantation. So one of the guidelines from SMFM says that at the time of the anatomic scan, there should be a careful exam of the placenta location, shape, cord insertion site, and if there's any evidence of vasoprevia. So just to make sure if you get a report on an anatomic scan that they've really made a point of looking carefully at the placenta. And some of the authors of the studies that have done this research have found that the strongest drivers of both early and late preterm bleeding were placental problems. So abruptions, previas, vasoprevias, and accretas, and hypertensive disorders. That again, there could be an issue with the placental methylation, and that these differences that we see, so differences between ART and bleeding, has to do also with whether they've had fresh or frozen cycles and whether the patients are using their own eggs or not. So we see that there is a greater risk for having these problems in ART deliveries, but we also see that there's even a greater risk in patients who have subfertility who are conceiving on their own. So we have talked about the shape of the placenta, but this is also looking at the function. So this was looking at abnormal placentation and placental accretus spectrum disorder. So this was a retrospective cohort of many pregnancies, of which 5% of them were IVF pregnancies. So they diagnosed placenta accretus spectrum disorder based on the pathology report of the placenta. So the overall incidence of the placental accretus spectrum disorder was about 4% in the general population of all of the placentas that they collected. But you can see with IVF patients, it was over 2%. With the non-IVF patients, it was just 0.3%. So definitely a higher risk in patients who have done IVF. And this is after adjusting for age, null parity, and year of delivery. And these authors, had some different ideas about, what it could be that causes this in patients. So it could be the treatment, but it also could be what these patients have gone through before they've actually conceived. Many of our patients have had hysteroscopy, either because they've had other issues, they needed treatment, or a lot of times people do hysteroscopy in preparation for IVF. They were wondering if having a history of a DNC, which many of our patients have, may somehow relate to how that placenta implants. And they also wondered if there was any impact of having decreased ovarian reserve on the way that the placenta implants as well. So again, we do think that maybe we see differences with hypertensive disease, possibly related to the placenta also. So much like we have SART in the US, this is an organization who works in the Nordic countries. So these are very large European studies that provide very good epidemiologic data as well. So this was looking at hypertensive disease among spontaneously conceived pregnancies, fresh cycles, and also frozen cycles. And they looked at odds ratios of having hypertensive diseases. So let's look at this. So we have hypertensive disorders of pregnancy and preeclampsia. We have naturally conceived, fresh embryo transfer, frozen embryo transfers. So we can see that, so the reference group is the naturally conceived patients. But we can see that with our frozen embryo transfers, we have greater risks of hypertensive disease and also greater risks of preeclampsia. And we do see that there are high, I mean, look, you can look at the odds ratio on this one. There's, you know, significantly higher risk with the frozen cycles than with the fresh cycles. There are some differences we see with the fresh as well. So these authors speculated that they saw a greater risk with egg donation and with frozen cycles. And they wondered a little bit about, so one of the differences between a fresh and frozen cycle is that there's, with a fresh cycle, there are still a corpus luteum or corpus lutea that are there, making different hormones like progesterone, maybe other factors as well. And they speculated if that was somehow protective and could explain the differences between what we saw with the fresh and frozen patients and the risk of hypertensive disease. Because there is this increased risk of hypertensive disease in pregnancy, it is recommended that low-dose aspirin be used for patients who have done IVF to reduce their risk of preeclampsia if they've done IVF and there's an additional risk factor. So again, this is not something that we usually deal with as REIs because I believe that this low-dose aspirin is started, I think, after the first trimester. But there are other risk factors in terms of age, and I think obesity is one of them. IVF is another risk factor that would be included in considering starting baby aspirin on your patients. There is a greater risk of stillbirth as well. There is a 2 to 3 greater risk of stillbirth, and it's also greater with fresh cycles. So SMFM recommends antenatal fetal surveillance of these patients at 36 weeks. There's also a greater risk of gestational diabetes in our patients who have done IVF. This was a nice cross-sectional study looking at the risk of gestational diabetes. The reason I like this study the most is that I feel like they did a pretty good job of trying to exclude a lot of different factors that would put people at risk for gestational diabetes. But even after excluding all of these risk factors, you can see here, so this is spontaneous pregnancy, ICSI-IVF, and IUI. I kind of think the other thing that's interesting about this study is this IUI group, because this IUI group, I kind of think of it as a subfertility group. Like these people have infertility, but it's likely that their infertility is not as significant as the people in this group. And it's interesting because we see differences. So we can see that like the risk of diabetes is 10% in the spontaneously conceived group, about 40% in the IVF group, and kind of in the middle at 25% with the IUI group. Hypertension, we see about 7%, about 20%, and about 14%. So they did think that risk factors for gestational diabetes did have to be age, BMI, what type of ART you did, and maybe even using progesterone. The next topic we're going to discuss is differences in birth weight. And we definitely see differences in birth weight in IVF pregnancies and also whether they have been fresh or frozen. So we're going to go through a couple studies looking at that. This was a study looking at FET, so frozen embryo transfers and fresh cycles on birth weight for singletons. So the average birth weight was about 3,400 grams, and there was about a 2.6% of being low birth weight. And about 10% of these infants were macrosomic. And frozen cycles were about 140 grams heavier than the fresh cycles. So we can see here, so the risk of having macrosomia, we got our fresh and our frozen. We can see that there's a greater risk of having macrosomia if that infant comes from a frozen embryo transfer cycle. They had a 1.7 greater risk. And this seemed to affect male infants more than female infants. This was another study looking at the differences between fresh and frozen embryo transfers. Again, this is the large European database. And we can see here that the fresh embryo transfer infants had a lower birth weight than the frozen embryo transfer infants. And this was also a great study because they looked at spontaneously conceived pregnancies as well. So when they looked at, so we have all different outcomes here. We have frozen, fresh, and spontaneously conceived, and same here. When they kind of summarize the findings, they can say that if we look at frozen versus spontaneously conceived infants, there's a higher risk for frozen, a higher risk of very low birth weight, SGA, preterm birth, and perinatal, neonatal, and infant mortality. When we compare frozen to fresh, there's a higher risk of having larger infants, so frozen compared to the fresh, and a lower risk of having low birth weight. So when I talk to patients, I basically, we talk about all these risks, and I say there are definitely weight differences in infants. They may be greater or they may be lower depending on how you end up ultimately achieving the pregnancy. But this is really tricky because we don't know what factor is contributing to the differences we see in growth. So it may be due to the IVF procedure itself. So the medications we use to create the eggs, the way that we prepare the endometrium is different with it's fresh or frozen. There are different culture media that we use and culture methods that are used in the lab. The culture media systems have growth factors, antioxidants, cytokines, vitamins, and we're not sure if these different factors or different environment that we're, exposing these embryos to affects genomic imprinting, methylation. There could be epigenetic disturbances of the genes that may affect the fetus or how the placenta forms. The cryoprotectants and the may affect enzymes, may affect epigenetic programming as well. So these are all the different things that can happen sort of in how we create the eggs and then how those embryos are kept in the lab and then potentially frozen that may account for differences. One of the things, though, that we don't quite understand is that the way that we've done IVF has been changing drastically over time. The culture conditions and the laboratory conditions have changed over time, and we haven't really seen differences in some of these outcomes. There also could be treatment and monitoring bias with how these studies are done. Sometimes, like if we're looking at frozen embryo transfers, it's hard to know like whether those embryos came from embryos that were created with ICSI or not. So sometimes it's hard to tease that out in these studies. And then of course, it's also hard to remove the impact of subfertility as well. So one of the recommendations related to this is that the infants or the fetuses should have they should have fetal growth assessed in the 3rd trimester, but not have serial growth ultrasounds. It is also known that IVF pregnancies and infants from IVF have a greater risk of birth defects compared to the general population. And this is another big SART study looking at a lot of different children, spontaneously conceived, and with treatment. And this is looking at major non-chromosomal birth defects. So what we can see is that the naturally conceived group had about a 1.9% risk of birth defects. With the intrauterine insemination group, it was a little bit higher at about 2.1%. ART siblings, so this is kind of getting at if there's anything that the parents could be contributing that maybe would have affected other siblings who were conceived without infertility treatment. So you can see that these are all about the same, but we do see a greater risk with the ART infants. The other thing that I like about this study that I want to point out, let's look over here. So this is looking at major birth defects. So this is fresh cycles, no ICSI. So again, ICSI is the procedure we use to fertilize the egg for men who have male factor infertility. So we also can see that this is ICSI is used, no MF is male factor. And then this is ICSI used, yes, there's male factor. But what I think is important about this is the use of ICSI without male factor infertility. And we can see that there's potentially a greater risk of birth defects when ICSI is used without an indication. And I think this is why our national organization has said that ICSI should not be used on all patients at all the time for a couple reasons. One, because there is an increased risk of birth defects and there's an increased cost. And so I think that's important to have patients recognize in sort of understanding when ICSI should be used in their treatment planning. It is hard to know if these associations are related to IVF or infertility or subfertility. The differences we see with IVF and ICSI could be related to an underlying male issue, maybe meaning that people who have worser infertility might be needing ICSI, and that is why they have a higher risk of having birth defects. Like, it has more to do with the parents potentially than the procedures itself. This is really hard to look at with databases, and as we talked about, it's hard to see sometimes when ICSI is used for frozen embryos, if that carries through to the data and the analysis. Because of this increased risk of birth defects that we see, it is recommended that a detailed obstetric ultrasound be done, for an anatomic scan to really appreciate if there's any birth defects that are seen in these pregnancies. One of the debates and this is actually one of the things that made me want to do this talk, was because differences in different ways that fetuses are looked at and different tests they have to undergo when patients have had IVF. But there was a little bit of a debate about the role of fetal echocardiograms in patients who have done IVF. And there was a big study where they looked at trying to understand if it was useful to do these. And it did say, or they did find, that congenital heart defects were higher in the IVF group compared to the general population. But the number needed to treat, or the number of fetal echoes to do, was 510 to be able to find one. So there is, it was questionable whether everyone should be having a fetal echo. And the SMFM guidelines do say that this should be offered to all pregnancies that were created with IVF and ICSI. When I've spoken to the MFMs at Ohio State, they've kind of said it also depends on how the anatomic scan is done, how good the quality of the images are that they've been able to get on the fetal heart, whether they feel comfortable or whether they need to have an echo done. So I think it also depends on, who's doing the ultrasound for you at your particular practice. So what is it? Is it the underlying infertility that causes these adverse outcomes, or something about the patients? Or is it what we're doing to the eggs and the sperm and the embryos in the lab? So in terms of the role of infertility, we do know from many studies that infertility or subfertility itself is associated with a higher incidence of adverse pregnancy outcomes. And these can be factors like maternal comorbidities. I mean, we do see differences in age, infertility itself. I mean, if we look at patients with PCOS having a greater risk of gestational diabetes, not because they did IVF, but because they have a greater risk of gestational diabetes because of PCOS. So sometimes it's hard to tease out the patient's other factors from the infertility treatment. We see abnormal placental pathology and preterm birth in both IVF and subfertile groups. But I mean, I think it's pretty hard to deny, with a lot of the more recent studies we have that have tried to look at subfertile populations, that we are getting worser outcomes with IVF. And there's higher incidence of, growth restriction and other adverse outcomes in our IVF pregnancies compared to those who have been conceived spontaneously. I think this was a very nice review that was done, which illustrates this. So we can see here just preterm birth, low birth weight, and small for gestational age. We have a subfertile group compared to fertile, and then ART. So if we look, subfertile groups, these patients all have a greater risk of these outcomes. When we look at ART, even compared to subfertile, we can see that there's greater risk of preterm birth compared to people who have infertility but conceived on their own. So what are we doing to these, like what's happening in the lab, or what's happening with how we make the eggs and the embryos? So how we create eggs is very different than how the body does it itself. So we have very high estrogen levels. We're making multiple eggs at once, and then we're taking the eggs from the body. The labs are wonderful places. They're amazing places where we can, create life, but there's a lot that goes into it. So the embryos are kept at very, very strict conditions with monitoring of temperature and pH and light and oxygen tension. And then there's the cryoprotectants that we use when we go to freeze embryos. So these can definitely affect all these different factors and epigenetics and enzymes and all the things we've already talked about. And then how are we affecting the gametes when we're preparing them? So we have the egg retrieval, we have ICSI, how we're affecting the sperm when we put it into the egg. Then we're transferring embryos, freezing embryos, and also, biopsying them as well. And this is just a slide looking at differences and all the different factors that go with, like, fertile patients compared to IVF patients, and then subfertility compared to IVF patients as well. I want to talk a little bit, just a second. Sorry, I have a cough. I just want to talk a couple minutes about multiple gestation, because I want to make sure that everybody understands how hard we're working as IVF providers to help reduce the risk of multiple gestation. And of all the things that I have no control over, like, I don't have any control over all of these things that go on in the lab, but we can really help people not have problems in pregnancy by helping them only get pregnant with one baby at a time. So why do people get multiple gestations? It's pretty rare with IVF now, but patients are under tremendous stress, mostly financial and probably time as well, to get pregnant as soon as possible. So, people will say, well, if I put more than one embryo in, will I have a higher chance of getting pregnant? Of course they will. They put 7 embryos in, they'll have a greater chance of getting pregnant, but that's not the right thing to do. In many of our states, most states around the country, there is no mandate, meaning that patients are paying out of pocket for their infertility treatment. And so they have a financial incentive to try to get pregnant. They may even think that it's better to have twins. They only have to pay for IVF once. So we see lower rates of multiple gestation in states where patients don't have to pay because they're more willing to take one embryo at a time. There are some clinics who want to have higher pregnancy rates, and so they get higher pregnancy rates by putting more than one embryo in. And I just wanted to note these cycles, so gestational carrier cycles, gestational carrier egg donor cycles, these are very expensive cycles. This is when, another woman's carrying the pregnancy, or in this, another woman's carrying the pregnancy and there's an egg donor. So these are the most expensive cycles, but these patients are also likely the most likely patients to conceive. So in some ways, those patients need less embryos, but we can see that the rates of twins are very high with these cycles. So I do think that that's a financial incentive that we're seeing there too. So with high order multiple gestation created from infertility treatment, SMFM does recommend discussing multifetal reduction with patients. So a lot of the infertility treatment, most high order multiple gestations are not made from IVF. Most of it is made from things like gonadotropins, and very rarely from oral medications like clomiphene citrate or letrozole. And so it's kind of hard, we can look at the IVF data very carefully because of the national data, but we don't have that same tracking for other types of infertility treatment. So it's not as easy to monitor, but it's been much lower over the last 20 years. So you can't even see, like on this picture, so this is with IVF. There's this teeny little blue line right here that's basically non-existent. That's triplets or more. So the risk of high order multiple gestation has gone from like 7% to like 0.2% over time. And I wanted to make sure that you guys understood this as well. So most clinics, I know that our clinic does this, and probably the Boston IVF clinics do this as well. These are the American Society for Reproductive Medicine guidelines and number of embryos to transfer. So I want to point out that most patients are having blastocyst embryos. And you can see, even if we don't do any genetic testing of embryos, we're not talking about putting 2 embryos in someone until they're 38 years old. So young patients really should only have 1 embryo put back. If patients have had genetic testing of their embryos, they only ever get 1 embryo, because as the patient gets older, there's a greater chance that that embryo doesn't have the potential to become a baby. So we try to compensate for that by putting more embryos in. But when we know that embryo is normal, they only ever get 1. So we really are trying to reduce the chance of multiple gestation. And look how good we've done. So I just want to show, these are some of the data from 2019. This is actually the CDC created these graphs. They monitor IVF data as well. But look, single embryo transfers, just 10 years ago, it was 18%. then it's 77%. So the most recent publication that came out from our national organization looking at the even more recent data than this said that 85% of embryo transfers are single embryos now, which is great. You can see, again, this teeny tiny line down here is triplets, but look, singleton rates going up over time, risk of twins going down over time with IVF. This is with IVF. And that's great, right? Because these are problems. So low birth weight and preterm, we can definitely see that when we have single infants, so much less than when we have twins. So we really, you know, I have patients say all the time, like, oh, we're good with twins, but no, like they're not good with twins. Like we really have to try to make sure we're convincing people that they just want to have one baby at a time. Because like I said, we don't have any control over all the other stuff we've talked about. This is where we can really make a difference with patients and the health of their pregnancy. So just as a note though, we still do have some monozygotic twins when we do IVF. So again, most of the twins we get from infertility treatment, Clomid and letrozole and all that, are from multifollicular development. Those are mostly digyzotic, but we still have about a 2% risk of monozygotic twins. So, you know, we put one embryo in and we get twins. That may have something to do with sort of like what's happening in the lab as well, or maybe something called assisted hatching, but it is quite rare. It's quite rare. So a couple other guidelines. So this wanted to make sure we went through these related to the SMFM guidelines. There is a higher risk of preterm birth, but you do not do any serial cervical lengths and you don't need to give any extra progesterone past 12 weeks. A couple things, just a couple of random things related to IVF I wanted to make sure that we shared from the guidelines. You can have lower PAP-A levels with IVF patients, which may make a difference when they're doing their nuchal translucency screening. May also give a false positive for aneuploidy. These patients may also, because of the differences we see with placenta, may have a lower fetal fraction in their cell-free DNA, which may cause them to have more failed results. I just want to spend a couple minutes talking about preimplantation genetic testing, because this is something a lot of patients are doing now, and you may have questions about that, or your patients may ask you questions about that. So again, we had it for aneuploidy, for recessive diseases, monogenetic disorders, and then balanced translocation patients. This, in a vast majority of situations, the vast majority of clinics around the country, this is you have to do a frozen embryo transfer because of the amount of time it takes us to have the biopsy celled. They have to get sent, they get analyzed, and for us to get the results, it takes a couple weeks. I want to just briefly talk about something called mosaicism. So you probably know that mosaicism is when there are two cell lines that are being created. So we can see this, like if, you know, somebody has a CVS, they can see mosaicism. And so, you know, the idea is that, like, what if there was a mosaicism on an embryo? Like, what if, you know, you're supposed to be biopsying the trophectoderm, which becomes the placenta, and the inner cell mass is over here, and that becomes the baby. But what if when you biopsy, you get a little bit of maybe two different cell lines, and maybe the result that you get on the embryo is not really representative of what this baby is going, what the embryo is going to become. But I think it's really important to understand that, unlike, you know, doing a karyotype on an adult or on a baby, when we learn about mosaicism on an embryo, it's kind of considered reported mosaicism. So it's not a karyotype diagnosis. It's inferred by the presence of an intermediate chromosome copy number on the testing that we're getting. There's actually a lot of different reasons why an embryo may be reported as mosaic. And one of the things that we've learned recently, like in the last couple years, is the companies that have been doing this testing have been reporting that embryos that have kind of lower levels of, are reported to have lower levels of mosaicism, were giving the same chance of getting pregnant and having a baby as embryos that were euploid. So in the last couple of years, some of the labs have changed their criteria for what's considered low mosaicism. And so there may be embryos that have been thought to be mosaic that have been transferred, and those women are pregnant and having babies. I have, I think, at least one or two, and they those babies had karyotypes and they were totally normal. So just one of those things to understand, because that may be something that may come up. So in terms of the PGT-A, it is still recommended those patients have normal prenatal screening, because there could be a difference between sort of the trophectoderm where the embryo was biopsied and the inner cell mass, which became the baby. There can be also a false negative rate. For people who may carry either, worried about a condition that their baby may have or a balanced translocation, it is recommended that they have confirmatory prenatal testing as well, and just understand the limitations with mosaic embryos or if those pregnancies need any additional testing. Usually if we're considering transferring a mosaic embryo, we do have the patient meet with a genetic counselor to talk about the implications of what that means. And so the guidelines would say offer prenatal testing to all patients, even those who have done pre-implantation genetic testing. So what kind of things should you ask about if you're caring for a patient who has undergone IVF? So it'd be helpful to know if that patient did a fresh or frozen IVF cycle and what kind of frozen cycle they did. Did they, do a natural cycle? Did they use letrozole? Did they have a corpus luteum? Did they do a programmed cycle? Those can all be differences. You want to understand if they used their own egg or not. And then you'd want to understand if they did any genetic testing and what type, and if they had a mosaic embryo transferred, sort of does that patient need any additional testing? All right, let's just summarize the recommendations from SMFM. So they say that all patients who have done IVF should have genetic counseling, and that they should all have prenatal screening offered to them, even if they've done PGT. It is important to understand the limitations of first trimester screening if patients have done IVF. If patients have high order multiple gestations, they could be offered multifetal pregnancy reduction. Because of the increased risk of birth defects, primarily congenital heart defects, we want to make sure you get a very good pictures of the anatomic scan, and maybe even consider a fetal echocardiogram. Pay very close attention to the report of where the placenta is and how it is on the anatomic scan. These patients do have an increased risk of preterm birth, but they don't need serial cervical lengths. They do have, differences in growth, so you want to assess fetal growth in the 3rd trimester, but they don't need serial growth ultrasounds. These patients may be considered higher risk, and having IVF is one of the risk factors for using low-dose baby aspirin. We want to increase or do antenatal fetal surveillance starting at 36 weeks. And then there isn't a clear guideline on delivery of patients who have done IVF. They say that shared decision-making should be done at 39 weeks, basically because we don't have a lot of data on what the right thing to do is for these patients. So I think it's important to understand that IVF patients do have additional risks. I don't think any of them would be significant enough to dissuade a person from doing IVF if that's how they wanted to have their family or needed to have their family. But we just want to make sure that we're giving them good care in the meantime. So I'm definitely open to taking any questions right now, and I hope that you enjoyed the talk today and learned as well. So thank you so much for joining us.
Thank you, Dr. Rossi. Great presentation. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions panel in your attendee control panel. Our first question is, knowing that there are some issues with IVF pregnancies, is there anything that can be done prior to getting pregnant to help reduce the risk during pregnancy?
Definitely. I think we always want to try to optimize a patient's health as much as possible before they do IVF. So this may be, maybe this person needs to have a preconception consultation with maternal fetal medicine. Maybe you need to have a conversation with them about weight loss goals before they do IVF, or optimizing, blood sugar levels before they do IVF. Really having a very clear history on their obstetric history, like are they at risk for any placental issues because of something else that happened to them. So I just, we always get a little bit stuck because a lot of our IVF patients, not all of them, but some of them are concerned about their age. So we can't spend a tremendous amount of time sometimes we're always kind of battling things like weight and age, but to the best of our ability, we want to try to help these women get as healthy as possible before they get pregnant. And then the other thing we can do to really reduce their risk is to really try to have them only get pregnant with one baby at a time.
Great, thank you. This next question, it was asked earlier in the presentation. You answered it during the presentation, but I'm going to ask it again because it is something that comes up often. And is, if a patient has done PGT-A, do they still need to do NIPT screening, or is that just a duplication?
Yeah, I mean, there's a couple reasons why it's recommended that they have non-invasive, or I shouldn't even say that, really any kind of prenatal testing. So when they go to biopsy the embryo, so there's two different parts of the embryo. There's like the part that's the inner cell mass that becomes the baby, and there's the part that's the trophectoderm, which becomes the placenta. So when they biopsy the embryo, they try to get the cells from the trophectoderm because they can't get it from the inner cell mass because that would, hurt the embryo. So there's always a small chance that the cells that become the baby are different than the cells that become the placenta. So that's a little bit of that mosaicism concept. So that's one reason why they recommend having that patient do testing to make sure to confirm that the results that we got from PGT are similar to the results that they are having with their prenatal testing. I think it kind of depends on a patient's level of comfort. If someone's on PGT, that might not be a person who wants to do a CVS, if they have no other risk factors, but maybe that is someone who might want to do non-invasive testing, or maybe that's someone who would do an amniocentesis. I think that PGT-A, I think is, you can have, some maybe a little bit more open with. I think sometimes when we're dealing with significant diseases, like for the families where they have a disease and they're doing the PGT-M, those people might be more interested in doing invasive testing to really confirm that that child doesn't have any diseases.
Thank you. The next question is, are there any ongoing studies that can answer why subfertility can lead to an increase of placental problems and complications?
I don't know of any. That there was one study we discussed where they looked at the pathology of the placentas, and I kind of thought that was interesting because, you could have a patient who kind of gets pregnant on her own and then there may even be some miscarriage patients that kind of fall in this category too, in terms of like what's going on with their uterus. I don't know of any ongoing studies, but I do wonder if some of the placental differences we see are within patients, who have infertility, who could have some sort of uterine factor, or it may be the fact that they've done a lot of treatment and had procedures done to their uterus. We do have some patients who have recurrent pregnancy loss and/or infertility, and there's a whole host of things we don't quite understand about uterine function in those patients as well. So I do think that one of the areas of research that we definitely need more information about is about the uterus, and implantation. And I think that what we're seeing with some of the placental issues has to do with sort of the uterus as well, basically.
The next question is, do you have any data on cesarean rates?
Oh, I don't have that handy. I do think that my brain's telling me that there are higher rates of C-section in women who have who've done IVF. I'm not quite sure where the subfertility women fall in that. I don't know. But I think it would be related to all the things we're seeing, right? So if you have a patient who has a higher risk of high blood pressure or preeclampsia, they're probably going to need it. They might be more likely to have a C-section because maybe they fail their induction, or maybe they've had a myomectomy and need to have a C-section, or maybe they have obesity and need to have a C-section. So I do think there are higher rates of C-section among patients who have done IVF. There probably is a little bit of that, like, strongly desired pregnancy thing there too, where people maybe aren't as willing to, you know, have the stress and the worry about trying to have a vaginal delivery. So I don't think that there's any indication, like there's nothing that says that patients should have a C-section if they've done IVF. I just think that for all the issues we've talked about, that puts people at greater risk for needing to have a C-section. I don't have that rate off the top of my head. I guess it's probably around 40%. I don't know.
Thank you. I appreciate that. That's the last question. So
Great.
Thank you, Dr. Rossi, and thank you everyone for attending today's webinar, Obstetric Outcomes in IVF Pregnancies. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Ohio Reproductive Medicine, and Dr. Brooke Rossi, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Rossi.
Bye. Thanks, everyone.